Today, we're tackling one of the most common and honestly one of the most confusing electrolyte issues you'll ever see on the wards, hyponatremia. Let's break it down.
So let's jump right in with a super common scenario. You're on call, right? And the ER pages you about an 80-year-old who's suddenly confused. You pull up the labs, and bam, serum sodium is 118. This happens all the time. And knowing what to think about next is absolutely key. So, where do we even start? Well, that's exactly what we're going to cover.
Okay, so before we can even begin to figure out what's going wrong, we've got to have a solid handle on how the body is supposed to work. Understanding the normal physiology makes figuring out the abnormal stuff so much easier.
Okay, here's probably the number one thing that trips people up with hyponatremia. They mix up two totally different ideas, tonicity and volume. Let's try and separate these in our minds. On one hand, you've got tonicity. Think of this as the concentration, like how salty are your body fluids. This is all about water balance, and it's regulated by thirst and this really important hormone, AVP. Tonicity is what determines whether your cells swell up or shrink. Then, on the other hand, you have volume. This is simpler. It's just the total amount of fluid in the tank. This is all about sodium balance, managed by the kidneys, and it determines how well your organs are getting blood flow. So here's the key. Hyponatremia is almost always a problem of tonicity. It's a water problem.
So let's meet the main character in this whole story, a hormone called arginine vasopressin, or AVP for short. Now, you've probably also heard it called ADH, or antidiuretic hormone. They're the same thing. It's released from the pituitary, and its job is actually pretty simple. It just tells the kidneys to hang on to free water. That's it. It's basically the body's main defense against getting too salty or dehydrated.
So how does it actually do that? Let's walk through it. Say your plasma gets a little too concentrated, or your blood volume drops. That's the trigger for AVP to be released. It then travels all the way down to the kidneys' collecting ducts. Once it's there, it locks onto these V2 receptors on the cells. And this is the magic step. Binding to that receptor triggers these tiny little water channels called aquaporin 2 to get inserted into the cell wall. And just like that, you've created a pathway for free water to get pulled out of the urine and back into the bloodstream. It's a really elegant system for fine-tuning the body's water balance.
All right, so that's how it's supposed to work. Now let's look at what happens when this whole system goes off the rails.
Listen, if you only remember one single thing from this entire explainer, make it this sentence. Hyponatremia is almost always a problem of too much water, not too little salt. The problem isn't that you've lost salt, it's that you have too much water on board and it's diluting everything down. The total sodium in the body could be low, normal, or even high, but no matter what, there's always relatively too much water.
And that leads us to what we call the final common pathway. You see, no matter what the initial cause is, most cases of hyponatremia end up in the same place. For one reason or another, you get inappropriate or just way too much AVP secretion. That leads to way too many of those aquaporin water channels getting stuck in the kidney cells. And the result? The kidneys just reabsorb way too much free water. And that water dilutes the plasma sodium. Boom, hyponatremia. It's a surprisingly simple mechanism that explains pretty much every case.
Okay, so we get the what now, but what about the why? How do we actually figure out what's causing it in a real patient like our 80-year-old from the beginning?
This is probably the most important clinical pearl I can give you. The single most important first step is to go to the bedside and assess the patient's volume status. Remember our tank analogy? We need to figure it out. Is the tank too full, too empty, or is it just right? Seriously, this one physical exam finding is going to slash your list of possible causes.
And this table here really helps organize our thinking. So if you examine the patient and they seem hypovolemic, dehydrated, dry mucous membranes, low blood pressure, you should be thinking about causes like diuretics, vomiting, or diarrhea. The body is desperately trying to hold on to water with AVP to keep the blood pressure up. Now, what if they're euvolemic? The tank seems about right, not too full, not too empty. That's when you start thinking about things like SIADH, the syndrome of inappropriate ADH, or maybe even low solute intake like the classic tea and toast diet. And finally, what if they're hypervolemic? They're swollen, they have edema. Now we're thinking about big picture problems like heart failure, cirrhosis, or nephrotic syndrome. In these states, the body is actually fluid overloaded, but it thinks it's underfilled, so it pumps out AVP anyway.
So, let's put it all together in a simple game plan. Step 1, measure the plasma osmolality. We need to make sure this is a true hypotonic hyponatremia. Step 2, like we just said, is the most important. Assess their volume status at the bedside. Are they dry, wet, or euvolemic? And then step 3, you'll want to check some urine studies, specifically the urine osmolality and urine sodium. Those 2 labs are going to give you huge clues about what the kidney is doing and help you nail down the diagnosis.
All right, so we've worked through the diagnosis, and now let's talk about management. And I gotta say, this is where we have to be really careful.
And the very first rule of treatment is basically a giant blinking red light. You cannot correct the sodium too quickly. If you go too fast, you risk causing a truly devastating and irreversible condition called osmotic demyelination syndrome. See, the brain has gotten used to this low sodium environment, and if you change it too rapidly, you can literally destroy the protective myelin sheath on the neurons. So the rule is always slow and steady.
So, what are our core principles for treatment? Well, number 1, and this is obvious but crucial, is to treat the underlying cause. If it's a drug, stop it. If it's heart failure, treat it. Number 2 is to correct slowly. The universal target is to raise the sodium by less than 8 to 10 points in any 24-hour period. For a lot of patients who are euvolemic or hypervolemic, the first thing you'll do is just restrict their fluid intake. And finally, what fluid do you give? Well, if they're dehydrated and hypovolemic, they get standard isotonic saline. But that special hypertonic 3% saline, that is reserved only for patients who are having severe symptoms like a seizure, and it's always given in a monitored setting like an ICU.
All right, let's wrap this up. We're going to pull everything together with a quick high-yield recap. This is the stuff you absolutely need to know for your exams and for your rounds.
Okay, here are your key takeaways. Number 1, hyponatremia is a water problem, not a salt problem. It's about having too much water. Number 2, the key hormone to remember is AVP, which works through those aquaporin 2 water channels. Number 3, your most important diagnostic step is to figure out the patient's volume status. Are they hypovolemic, euvolemic, or hypervolemic? And number 4, the biggest risk, the thing you have to be most careful about, is correcting too fast. Always go slow.
If you can just burn this one sentence in your brain, you will have a rock-solid foundation for understanding, diagnosing, and safely treating this condition. At its core, hyponatremia is a water problem, not a sodium problem.